Hello, ladies and gentlemen. It's a pleasure for me to welcome you here to this industry symposium, a satellite symposium sponsored by Oculus. The topic is Modern Cataract and Refractive Surgery, the next level, and you will see 4 presentations dealing with the Pentacam AXL Wave and the Keratograph K5M, and how this can help you to have a very good cataract and refractive practice. And I'm joined by Dr. Fernandez from Spain, Dr. Faria Correia from Portugal, and Dr. Baptista. And I think we will listen to very interesting talks. If you have questions, please use the Q&A thing in your browser, and we are happy to answer it as good as we can. So without further ado, I would like to start with the first presentation from Dr. Fernandez on Pentacam AXL Waves, the complete device for refractive presbyopia and cataract surgeons. Can you start the video, please?
Well, we are going to talk about the Pentacam AXL Wave, the complete device for refractive presbyopia and cataract surgeons. This our conflict of interest this last year. Well, let's take a look at what the content of the presentation will be. We are going to start by talking about the historical evolution of what Pentacam was born as tomographer and evolved up to become what we call the complete device, or the most complete device on the market, not only in terms of hardware evolution, as we will see, but also in terms of software evolution. We will make a brief review of the new features around the full sequence capture and each of the new options of the Pentacam Wave version. We will see how each of Pentacam summaries provide useful information in the preparative period from both laser refractive surgery and cataract surgery. Pentacam was the first device based on chain fluid technology that allowed us to measure the anterior segment by means of cornea and anterior segment tomography in 2002. In 2007, Pentacam received a hardware update, increasing the resolution of the device. But it was in 2015 when the major hardware change emerged with the incorporation of the measurement of the axial length through partial coincident interferometry as the IronMaster 500. Pentacam AXL became again the first tomographer incorporating a biometer, resulting in 2 devices in one, and allowing not only the anterior segment diagnostic, but also the intraocular lens power calculation. But evidently, in all this year of Pentacam evolution, this had not been exclusively about the hardware, but even more important, that the evolution of the hardware has been the evolution of the software, creating tremendously useful tools for clinical practice that we are going to go to review. Simply so that you know, in general way, some of the most important ones, since many other screen of a model are included. Well, we could start, for example, with a fast screen report, where we can visualize the normality of parameter measured by Pentacam in comparison with what would be pathological population. With this model, we could quickly detect problems of cornea astasia or lens opacity through the Pentacam nucleus staging. Without a doubt, a great tool because it gives us information not only about what we are seeing, but also about if the values obtained are normal. This is extremely necessary, especially for those who have less experience or less knowledge of the normality of these biometric parameters. In addition, it includes a specific module for the detection and control of the keratoconus progression. The following maps are widely known and described in the Pentacam history. For example, the Belling-Ambrosio and the Belli ABC module. We can compare different maps and different times, so we can also monitor the curvature, evolution, or elevation changes in the obtained topograph map. We also have corneal densitometry option. With the tool, we can assess how transparent the cornea is, so we can visualize or detect if there is any other problem of loss of visual quality that may be due to a loss of transparency of the media. We can also see if the loss of visual quality, of optical quality, instead of a transparency problem, could be due to the cornea irregularities, which increase the height of the aberration mainly on the anterior cornea, but also the role of the posterior cornea. We also have information on how the power distribution of the cornea varies, which can be of great interest to understand how the refraction could change with the pupil diameter or the calculation of the intraocular lens, depending on the radial core which is evaluated. As we have already said, there are a multitude of maps that you can consult in the analysis section, and you only simply have to select those the best suit your needs. For example, we also have maps for ring segment implantation, for contact lens fitting. In other words, Pentacam is not exclusively something focused on the anterior segment surgery, but it would also have other application within the ophthalmology and optometry practice. As we have already said, all this that you have seen so far, it's only a part of Pentacam has evolved incorporation a specific evidence-based model that allow us to improve our clinical practice. This is one of the differentiation aspects that we believe sets Pentacam apart of the competition. Although other biometers may be able to measure axial length with more advanced cataract, as in the case with switch-sort technology, these other devices do not integrate all the knowledge acquired over the years and place in the hands of the surgeon so that we can put into practice. As if they are not enough, Pentacam evolved in 2019 with the ability to measure total aberrometry and other very useful options for the anterior segment surgeon that we will describe along this presentation. If Pentacam AXL were two devices combined in one, the Pentacam AXL Wave is more than three devices combined in one. The device incorporates a Harman-Shack barometer that allows not only to detect a loss in optical quality due to transparency or cornea aberrometry, but also any irregularity produced by both optical media, cornea, and crystalline lens. This has been up to date the result of 20 years of continuous development in the hardware and software of this amazing Oculus device. Now, we are going to see what's all the clinical ones to measure as much as possible in the most precise way and spending less time than ever. All the measurement of Pentacam and consequently taking without needing the patient to move from the chair test. This measurement are also perfectly organized to avoid that previous measurements can affect to the posterior measurements result. For this purpose, the system starts with the environmental light at mesopic condition, measuring the total aberrometry and mesopic pupil size, taking 3 average measurements in only 15 seconds. The next measurement is the retroillumination, which takes 1 measurement in just 10 seconds. The cumulative time would be around 25 seconds, adding the previous aberrometry capture. We continue with the axial lens measurement. Up to 6 measurements are taken, which take about 20 seconds. Up to this point, we would have spent about 45 seconds on the measurement. Finally, we finish with the corneal tomography and photopic pupil diameter measurement. The reason why this is the last measurement is due to we are going to induce glare with a rotational slit source, and therefore this could affect to the mesopic pupil side if the order would be inverted. In 10 seconds, 25 sections of the cornea are measured to create tomography maps. Take notice that we have complete all the measurement around 1 minute and compare the time you would spend if the patient has to move between devices and rooms. In summary, why do we use Pentacam AXL Wave? First, as we have already said, because it reduces measurement time and maximizes the collection of useful information for both preparative cataract screening and refractive, as well as other applications in the case of patient monitoring. This is the first summary of the result that we are going to review quickly. You can see that we have the pupil diameter measurement in photopic and mesopic condition, which is especially useful in cataract surgery in the selection of an aspheric intraocular lens or in the selection of a multifocal intraocular lens. On the other hand, in the case of laser surgery, when assessing the influence of the size of the optical zone in the generation of dysphotopsia. How was the pupil measured in our center before Pentacam AXL Wave? We used the keratograph K5M, which measured the strength of the mesopic pupil and photopic pupil after a flashlight source switch on and during a period of time. It is important, you know, that the light source measured in our center in around 500 lux, and this can differ from other devices using other intensities. Here you can see, for instance, the difference of measuring the photopic and mesopic pupil diameter with keratograph and Pentacam AXL Wave. The light intensity in Pentacam is lower than keratograph, around 300 lux, and this means that the pupil expected with keratograph is going to be 0.3 millimeters smaller. On the other hand, mesopic pupil diameter measurement could be considered as interchangeable. Then we can see at the right side the objective refraction and high order aberration obtained for total waveform measurement with a Harman chart. Another instrument that we can eliminate from the patient journey is the autorefractometer, because this objective refraction is already measured with Pentacam AXL Wave. 5 devices in one up to this moment if we consider the static pupil measurement and objective refraction in addition to the previously described option. Furthermore, we have in the field sequence overview the retroillumination and the densitometry for detecting opacities in the cornea and crystalline lens. But the application of retroillumination goes beyond in the intraocular opacity detection. Thanks to the software, we can also measure intraocular centration and rotation of the lens. Here you can see how we did in our clinic before Pentacam AXL Wave. We needed to take a picture of the pupil, and in the case of a diffractive multifocal intraocular lens, to measure the relative decentration of the first ring from the center of the pupil. This time-consuming procedure that we have created with Pentacam AXL Wave. If you navigate to retroillumination model, you only have first to select what would be your reference point, either the vertex or the pupil center. Rotate the handle in the rotation of the decentration, crossing half the first ring. Finally, select the caliper and over the handler measure the distance from the center of the coordinates to the ring center. As easy as that, and we do not have to take more eyes picture to report intraocular lens decentration. We can also measure the AXL lens and calculate the intraocular lens power. Pentacam incorporates a very useful system with different screens that can be customized by selecting the intraocular lens and formula we decide, such as Barrett Universal, Hofer, Olsen, or Haggis, among others. You can even optimize all this content if you want from other biometer. Our recommendation is you do at least a retrospective optimization of your constant. In our experience, we have achieved accuracy of 95% of 5 in 0.5 dioptries using our own formula and bore surface of the cornea for calculating the intraocular lens power in normalized. We are going to see a clinical example of a patient implanted with a torical lens and followed up postoperatively. We will discover how Pentacam AXL Wave help us to understand the obtained clinical results. The first thing we do is to use the cataract model to obtain the anterior and total corneal astigmatism in the preoperative measurement. In this patient, we can see that the measurement of both the total corneal refractive power, and the total net power is around 1.5 battery. But we can also see, in comparison with another device, we use that the anterior astigmatism is slightly lower, but considering the apolafia regression method, a higher total anterior against the rule astigmatism is present. In the end, we decided to implant a toric intraocular lens. From the practical use of the tools we have described, it is important to note how we can visualize how the anterior astigmatism or the total astigmatism is positioned depending on which one we choose over the retroilluminated image. At this point, we can see the vessel position that could serve as in the postoperative period to follow up the intraocular lens rotation. Here you can see an example of rotation measurement in the postoperative period. We place the short handler in the steep meridians and the long handler parallel to the intraocular lens mark. The off-axis position in reference to the steep meridian is around 10 degrees. Therefore, is expected at 33% loss of power. We can expect a residual refraction of around half dioptries due to this power of loss. During the postoperative period, we measured the objective refraction astigmatism, which predicted this half dioptry, but the patient preferred just a slight positive sphere in the subjective refraction. As you already know, objective refraction should be only the starting point, and it is required to fit this refraction subjectively. In the postoperative period, we can also see that the total corneal refractive power has been reduced. This has sense considering the temporal incision and the against the root preparative astigmatism. Several variables have slightly changed in favor to eliminate the astigmatism in such a way that the off-axis has been negligible in the subjective refraction of the patient. We have also to consider that the patient have some corneal spherical aberration that even thought has been reduced could partially compensate the blur produced by a low residual astigmatism. This corneal spherical aberration also explains why the patient even thought it was not bothered by photic phenomenon, resulting in a distortion index higher than expected with monofocal lenses. In conclusion, we have reviewed only some reasons which answer the question why Pentacam AXL Wave is the complete device. It is the complete device because do not only measure all the useful biometric eye parameters, because it provides the most powerful evidence-based software developed through 20 years of history, and because it fits the needs of different specialists.
Yeah, thank you very much, Dr. Fernandez, for this excellent in-depth talk, and we will go directly to the next lecture, which also incorporates the Cataract 5M as an additional tool in cataract and refractive patients. So thank you very much, and please start the next lecture. Hello, ladies and gentlemen. It's a pleasure for me to share with you my pearls for cataract and refractive patients when we are using the Pentacam AXL Wave and the Cataract 5M. My disclosures are listed here. And when we look at the Pentacam, we have already seen all the developments over 20 years now. The very first launch of the Pentacam was in 2002 at the Academy, followed by the Pentacam HR, later on then the Pentacam AXL, and then 2 years ago the Pentacam AXL Wave. So we have a huge development here. When I look what I use nowadays, I can say that almost anything in the anterior segment which is relevant can be screened. Comorbidities, Berlin Ambrosio, early ectasia screening, a special display for refractive corneal surgery or post and pre cross-linking, the anterior chamber anatomy for phakic IOLs. And there's now a lot of new stuff in it for IOL selection, optical biometry, special IOL calculator, and also the visualization of vision quality, which is very important. Pre and post-op also for follow-ups is implemented here, and I will show you how we use it. The difference to the AXL, there are a couple of features new: objective refraction, visual performance analysis, and also the IOL calculation with special formulas. So this is a full sequence overview in a phakic normal eye, what you see is first the total visual performance here. This E sign gives you the image quality, so to say. Iris image viscotopic, retroillumination photo, iris image photopic, then the refraction, the barometry, axial length biometry, tomography. And when we look at this, we see that this is not a very crisp image, and we can say, if we look at the visual performance outline, we will differentiate between the barometry of the entire cornea, which looks quite fine here actually, and then of the internal aberrometry, which includes the intraocular lens or the crystalline lens, and which is very fuzzy here, and then the total aberrometry. And here it's pretty clear that it has nothing to do with the cornea. And in retroillumination, you may already see some cataract formations or other things. Hartmann-Shack array has created all these images, and we see here that the reason for this is the lens. It can be an early cataract or presbyopia, so we can differentiate very nicely here. So for everyday practice, we use the visualization of the wavefront of the cornea, internal and total. Quite often, actually, the retroillumination photograph is also interesting when you look at the markings of a toric lens, for example, or a PCO or cataract, also to document that there is a cataract. Then the axial alignment of a toric IOL I just mentioned, you can overlay also with the corneal tomography, so you can see if the lens is really allocated at the appropriate place. Let's look at some clinical cases. Here, for example, we have a trifocal toric patient, got implanted, a myopic patient, you see, +12 with 3 diopters of cylinder. Target axis was 100 degrees in the right eye, in the left eye 91 degrees. And then we see that his refraction has still some astigmatism, as you can see here, almost 1 diopter, so 1/3 of the refraction has gone, so to say, of the effect of the toric lens. When we look at the Pentacam, we see that there's a regular astigmatism here. We look at the overview. We see a pretty good total visual performance, because if it's only a little bit of astigmatism, it will not have such a huge impact, as you can see here. But we see here a fuzzy corneal image, which is true. There are 3 diopters of astigmatism here. Then internal is also a little bit fuzzy because we have a toric lens, and the total is okay, but not optimal. Yeah, cornea, internal, and total. So we have to look about the location, and we can see that the IOL is 10 degrees decentered or rotated. 10 degrees would be 30% of less effect. So from 3 to 1 diopter, it makes sense that the patient accepts this. We can use, for example, the calculator from Birdall and Harden to see what the rotation and what direction would bring in terms of better performance. So this is more or less a standard, and you can see that you can improve it like by 1/4 of a diopter to 1/2 a diopter improvement, which may be 1 line better uncorrected in this patient. But the Pentacam also can do that. You can use the Barrett RX formula setup here. For example, you look at a patient who has an implanted lens. This is not the same case here, another case. And then you want to see what is this refraction. You see what the parameters of the phakic eye are. And then you can look at a certain method if it's related to, for example, a corneal issue like post-LASIK, or just the positioning of the lens, rotation or tilt or something else. Then also the Pentacam can calculate that for you. There are 3 methods: exchange an IOL, do a piggyback toric IOL, or do a rotation of the toric IOL. And each momentum can be displayed and also given you an idea what would be the right way to do. In this specific case here, you see the rotation. If you would put a piggyback IOL on it, it will calculate that. If you would exchange the lens, it will also give you the new numbers for the lenses. So this is a quite interesting tool. Let's look at a real patient where I use the Pentacam AXL Wave for my diagnostic procedures. For example, here a 56-year-old presbyopic patient came to me. He had myopic LASIK 14 years ago, right eye had a slight amblyopia, left eye was a distant dominant. Now after 14 years, his uncorrected visual acuity was 0.4 on both eyes, with a hyperopic correction, so he had a over a regression, so to say. He gets to 0.63 on the right eye and 1.0 on the left eye. And I don't show you which lens I choose. I'm hiding that here, but you see, otherwise this is with the HiGS-L formula calculated. You see here his values on the IOL master. So we have a presbyopic patient, we have a patient with amblyopia, we have a patient who has undergone LASIK. So there are a couple of features. And this patient comes to you and says, can we do a refractive lens exchange? I want to be free of glasses. I want to have a multifocal lens, trifocal preferable. So what can Pentacam tell us? Well, if we look at it, here is the right eye. And if we look at the data here specifically, I look at a couple of things. The cornea itself looks pretty normal. Astigmatism is not really a huge issue. But what's important is there any issues in terms also of optical axis? We see here pretty normal values for chord mu and chord alpha. And we also look at the aberrations, and we have different zones, of course. If you look at the total corneal high order aberrations, 0.165, it's not a low number, but it's also not a very high number at that aperture. The spherical aberrations, however, are pretty high actually, with 0.329. Even though it's a 6 millimeter zone, it's pretty high, so we have to keep that in mind. The other eye, when we look at this, we have similar conditions, not much different from the right eye. So when we think about a solution for IOL calculation here, we should, for example, also look what is normal, what is not normal. So the high order aberration, as you can see here, are this is from a study we did on normative data, where we looked at several hundred patients, what is normal in high order aberrations or spherical aberrations. And we can see here the high order aberrations in general are in his age group over 50 are within normal limits. If he would be a little bit younger, it would be out of the limits. But the spherical aberrations are pretty high actually. I have here the data from the 4 millimeter zone. I don't have the 6 millimeter for this lecture, but it doesn't matter. Even with 6 millimeter, the average would be here, so they are above this. So we wouldn't really use a trifocal lens here. We have an amblyopic eye, right, which is not good, and then we have very high spherical aberrations, and then we have the uncertainty of IOL calculation. So what I did actually was using a non-diffractive EDOF IOL, in this case the IQ Vivity. We were calculating it different ways and coming up with these diopters. We did temporal incision in both eyes to correct a little bit astigmatism. The right eye, I was happy to leave a little bit of myopia, so a kind of mini monovision. He ended up like a minus a quarter of a diopter, so to say. The left eye, we really hit the point, and as you see here, the binocular visual acuity, 1.0 distance, 1.25 intermediate, 1.0 near, was the right choice, and he has no side effects because it's a non-diffractive technology. So here the Pentacam helped me for the decision. Let's move to the other machine, the Cataract 5M, which I really like very much. I use it especially for dry eye screening, independent from the corneal topography. I like that very much. It is a system that can do a couple of scans. Yeah, you see here the tear film scan, MIBO scan, imaging, different types of magnification and different aspects of the tear film, or the anatomical situation is displayed here. You need different optical magnification changer here, because sometimes you look at the whole eye and want to see the redness, then you want to see the whole cornea, or you want to see the center of the cornea and the tear film, so to say. So all this is implemented here, and automatically it's done. And there are a couple of things you can measure here with the tear film scan. You have the meniscus height, you have a non-invasive breakup time. You can look at the lipid layer. With the MIBO scan, you see the mibography, which is quite nice. And the redness of the eye can also be quantified. And there are some other imaging things you can do on the conjunctiva. So if we look at our strategy also to treat evaporitive or aqueous deficient dry eye situations, we can really very nicely implement the Cataract 5M and find the way to the right decision here and even quantify the amount of severity very nicely here. You get this kind of 9 picture sheet here where you see all critical issues, and this is displayed in a specific report that you get, which includes also a specific kind of ranking or a visual analog scale. From green everything is normal to red everything is not normal, and here for the tear film, for the lid margin, for the lid function, blink frequency, conjunctiva, and there's also a questionnaire that gives you some answers here. Here you see nice pictures of a myopography, so you can really nicely see what's going on here on those eyes, or the non-invasive keratograph breakup time. Here you really get a landscape, and what you want is a very straight line and more or less green tomography or topography picture here. So when we look at this, we can also educate our patients. We can say, look, this is the reason why you don't see good, or why we have to use this or that type of dry eye medication. And then he gets a printout, and in this printout you get like this Pentacam type of evaluation. So 5 critical things. If you're all in the green area, is good. If one of this is in the red, you can tell the patient. You also see it here on these lines. What is right and what is wrong. Let's look to the clinical cases. We have a patient here, femtophaco with implantation of a trifocal IOL, uncorrected visual acuity on the left eye. First week post-op was 20/20, 1.0. Patient was happy. Then patient comes 4 weeks for a follow-up. Visual acuity dropped down to 0.4. Now, there's a lot of reasons why you can have 0.4. One thing would be a wrong IOL calculation, or you can also have a macular edema, especially 4 weeks would be good. So you can exclude that, but still you have to explain to the patient why the visual acuity went down. And in trifocal lenses, you don't want to have that happen because the neuroadaptation is stopping at that point. So the topography was not really very interesting here to say about this patient. So the Pentacam alone didn't help us much, but when we did the keratograph, we look at different things. Here you see the meniscometry, and you see already a difference between the right and left, but not really very extreme. Then the interferometry showed in both sides lipid deficiency. However, this is a patient who also got 3 weeks antibiotic and steroids, so this has an impact, of course. But the real reason was here the breakup time. You see one eye is completely normal, the other eye is very bad. And this is very easy to say here for the patient also. The reason for the loss of visual acuity, he got treated by dry eye treatment, also with a little focus on the lipid deficiency. Then patient was fine and everything went well. So is it always a problem of surface things? Here we have a younger patient who got a femtophaco with implantation of a toric monofocal lens. Here almost 4 diopter of toric correction. First day post-op, everything was fine. Patient uncorrected 0.8, was very happy in these things. 2 weeks later he dropped down 3 lines, but you could correct him to 1.0 with some astigmatism. And of course the cornea hasn't really changed much. If we look at the images, we don't really see much with the Pentacam here because the 1 diopter astigmatism alone is not really changing extremely the whole visual quality image. When we looked at the Genvis report, we couldn't find really any big problem here. And but if we looked at the Pentacam and we checked the axis position, we could see that we have a 10 degrees rotation. 10 degrees means 30% of effect of the toric lens is gone. In 3.75, it makes sense that she now accepts 1.25. So that was the reason, and we didn't wait for anything, we didn't do any treatment, we just did a re-rotation, and then patient was happy. So to summarize, the Pentacam AXL Wave is an excellent machine for preoperative evaluation of our cataract refractive patients. Everything we need is in there. Post-operative evaluation is also very good, especially problematic cases, unhappy patients. And the addition of the keratograph is an excellent tool because dry eye symptoms, surface problems are very, very often, especially in the early post-operative time, in refractive as well as in cataract patients, and especially premium lens patients can suffer from it, and it can have a problem in terms of the neural adaptation and all this stuff. So I really love this tool to use it in my patients. So if you ask me if it's worth this, I think it's a win-win situation if you use both machines in your daily practice. Thank you very much for your attention. Yeah, thank you very much. We are going from one talk to the other in order to get you as much information as possible. Now we will listen to Dr. Faria Correia from Portugal, the Pentacam indispensable tool for him. So please let us see this lecture.
Hi, my name is Fernando Faria Correia, and in the first place, I want to thank Oculus for the lovely invitation to speak in their symposium. These are my financial disclosures for today's talk, and I want to show you some clinical cases that illustrate that the Pentacam was useful to solve the problems of my patients. Basically, I use this device in three types of situations: patients with keratoconus, patients that are looking for a refractive surgery solution, patients with cataract, and this tool is very useful because it helps me to select the more suitable patients for premium IOLs. Regarding keratoconus, I want to highlight the ABCD grading system that was developed by Michael Bellin and was designed for keratoconus staging. This system enrolls for different parameters, as you can see here in this slide. The A stands for the curvature of the front surface, which is centered in the thinnest point. B represents the curvature of the posterior surface, which is also centered in the thinnest point. C represents the thinnest point value, and D represents the best correctable visual acuity of the patient. So in this slide, you can see this display that shows a patient that underwent 3 sequential scans in 3 distinct dates. You can see that last scan that is represented by the blue line, that the patient presented signs of progression because the posterior surface got steeper, despite the absence of change in the anterior surface and in the pachymetry readings during the follow-up. So this system can be very helpful for the physicians in order to spot mild corneal changes that are representative of progression in these type of conditions, corneal conditions such as keratoconus. So now I'm going to show you some clinical cases from my daily practice that represents patients with keratoconus or patients that are looking for a refractive surgery solution. So the clinical case number 1 represents a patient that had keratoconus. The patient underwent penetrating keratoplasty in the left eye and who was complaining of contact lens intolerance in the right eye. The best correctable visual acuity of the right eye was 510 with -13 of sphere. The slit lamp showed no scars, a clear cornea, and some Vogue stria. And the Pentacam, as you can see here, shows a nipple cone with a high sphericity value. Based on this clinical and tomographic data, we proposed the patient to implant an intercorneal lens segment, and the procedure was femtosecond assisted. The patient was very happy during the follow-up, and at the 6-month post-op visit, the patient presented a visual acuity of 710 with -8 of sphere, and the patient, compared with the pre-op data, you can see here that it was tolerant to the contact lens, and we used the soft contact lens to improve the visual rehabilitation of the patient. The patient presented a visual acuity of 810 with a Bausch & Lomb Vision contact lens, and the patient was very happy with the solution that was proposed to him. So I want to highlight this slide because it shows that the Pentacam help us to understand the effect of the surgeries. Basically, the comparison map, because we subtract the post-op map from the pre-op map, we can understand the therapeutic or the refractive effects of the procedure that the patient underwent. So you can see here that there is a huge central flattening that was promoted by the intercorneal ring segment and help us to justify the increase of the best correctal visual acuity, and also the patient got improved also the contact lens tolerance after the procedure. Regarding the clinical case number 2, was a patient that was looking for laser vision correction due to contact lens intolerance and dry eye. As you can see here, the vision was pretty fine with the refraction, mild myopia. The slit lamp also showed some signs of dryness. And here you can see here that the anterior sagittal curvature map show a mild inferior steepening that can be representative of ectasia. But the corneal tomography exclude that hypothesis because the patient presented a good cornea in terms of thickness. The pachymetry was above 600 micron, and there was no yellow and red flags in the elevation data, and also on the pachymetry regarding the progression and the relative pachymetry indexes. Regarding the left eye, there is also a mild inferior steepening in the curvature map, but here you can see that there are some yellow flags, especially in the assessment of the elevation of the back surface, centering the thinnest point. Regarding the pachymetry, the patient also presented a cornea in the left eye that was the pachymetry was above the 600 microns, so there was no ectasia here presented in this patient in both eyes. So basically, we discussed the patient available options to correct the refractive error, but in first place, we performed an ocular surface optimization in order to promote the refractive error correction after the procedure, but also to solve some of the problems that were presented by the patient in the pre-op assessment. So, based on the clinical data, since the patient presented a mild discomfort of the contact lens due to the dryness, we offered the patient's PRK. Also, the patient was a boxer, and due to this fact, we thought that the advanced surface ablation was better compared with the phantom-assisted LASIK. We offered the patient a topo-guided ablation to correct the myopia and the astigmatism. And regarding the 3-month post-op data, the patient was very happy with uncorrectable visual acuity of 10/10 in the right eye and 12/10 in the left eye. And here are the comparison map. And that as I stated you before, these are a very interesting tool in order to show the patient what we did with the laser. As you can see here, the laser promoted a central flattening of the cornea, but since we use a topographic ablation in order to eliminate some of the corneal irregularities, you can see here very clearly where were the irregularities on the cornea before the surgery. So this is a very interesting tool in order to understand the therapeutic but also the refractive effects of the procedures that you offer to your patients. So regarding cataract, and this is my last slide, I want to highlight also some of the functions of the Pentacam, because with the cataract pre-op display, it helps me to select the patients that are more suitable for premium IOLs, and I'm talking about multifocal and toric IOLs. Also, Pentacam allows you to evaluate objectively the densitometry of the crystalline lens in patients with cataracts. The parameters of the densitometry show the good correlation with the LOX3 grading system and also with internal wavefront analysis, and this can be used to document cataract for insurance purposes. Also, the densitometry show the good correlation with factor energy and can be used to plan the cataract surgery in order to promote a safer and a more efficient surgery in terms of energy consumption. So that's it, and thank you so much for your attention.
Yeah, thank you very much for the very nice examples here. And we will go directly to Dr. Babista, who will talk about the ectasia risk assessment prior to corneal refractive surgery based on the tomography and biomechanics. So I'm looking forward to hear this lecture.
Good afternoon. My name is Pedro Manuel Baptista. I'm ophthalmologist in Centro Hospitalar Universitário do Porto, Portugal, and I'm very pleased about the invitation by Oculus to talk about the theme in which I'm doing my doctoral project. I don't have financial disclosures to declare. First of all, cornea has elastic and viscous properties, making it a viscoelastic tissue. The first is due to the capacity to recover to its original shape after a given force is removed. However, the second makes the recovery delayed with some energy absorbed by the system, which is called hysteresis. In fact, corneal hysteresis was for a long time the main descriptor of corneal biomechanical behavior, but nowadays Corvis can give a more complex description, as I will explain. Many algorithms exist for the topographic and tomographic detection of corneas at risk for post-refractive surgery ectasia. Back in 2014, Professor Cynthia Roberts proposed in her great work that the reason for the difficulty to find a universal screening tool based on corneal morphologic features is that curvature, elevation, and pachymetric changes are all secondary signs of both keratoconus and post-refractive surgery ectasia, and that the primary abnormality is in the biomechanical properties. It was further proposed that the biomechanical modification is focal in nature rather than a uniform generalized weakening, and that the focal reduction in elastic modulus precipitates a cycle of biomechanical decompensation that is driven by asymmetry in the biomechanical properties. Given this, a repeated cycle of increased strain, stress redistribution, and subsequent focal steepening and thinning is initiated and perpetuated with progression of the ectasia. Regarding post-LASIK ectasia, I brought this work with a retrospective analysis of more than 30,000 eyes, showing that, besides rare, the current widely accepted risk factors like corneal thickness, topographic irregularities, ectasia risk score system, percent tissue altered, or residual stromal bed were not sufficiently rigorous for screening out potential ectasia from developing after LASIK. In fact, this only proves that what was known before, as I will explain ahead with the works that originated some Corvis parameters. So let's talk about the technology. Corvis is a non-contact tonometer with an acoplated ultra-shine flow camera capable of recording the cornea deformation process after the air puff. This way, a video showing the total inward and outward movements of the cornea in an horizontal cross-section of an absolute time of nearly 35 milliseconds is presented. Three main stages are analyzed: first applanation time, time of highest concavity, and second applanation time. Some other time points are analyzed but are out of the purpose for this presentation. Then, a thorough analysis of corneal biomechanical behavior in relation with the intraocular pressure is made, and is usually referred as dynamic corneal response analysis, encompassing both first and second generation parameters nowadays, as I will explain.
One thing more, in the power supply of the HDA, you can.
These are the first generation parameters. As I will explain ahead, at the point we stand today, these first generation parameters were surpassed by the evolved ones and are not usually analyzed individually in the subset of refractive surgery. I don't have time to explain each of it. However, I want you to keep in mind the basic way of thinking if you want to analyze it. Eyes with decreased stiffness are expected to be associated with higher values on the deformation and deflection amplitudes, deflection areas, and applanation lengths at all time points. The velocity at applanation 1, time at applanation 2, and peak distance at highest concavity are expected to be higher too. On the other hand, the time at applanation 1, the absolute velocity at applanation 2, and the radius of curvature during highest concavity are expected to be lower. Finally, within this setting of a single parameter analysis, time at applanation 1, time at applanation 2, and highest concavity related parameters were the first regarded as being the most important. There are evident limitations of any single first-generation parameter to describe the complex corneal biomechanical behavior. Plus, the dependency on intraocular pressure is a major handicap. So, large amounts of data from all these parameters started being analyzed through various methods which aimed to develop characterization models of greater consistency, resulting in the second-generation parameters. These are in constant evolution, and I will center my talk on the most relevant for the refractive surgery subset nowadays. First, the ratio between the deformation amplitudes at the corneal apex and at 2 mm from each side can be assessed during the entire corneal excursion. A function describing the inverse of the radius of curvature can be calculated during the entire excursion. Then, an important value is the area under the curve of the aforementioned function. As the Corvis includes a shine flow camera, it is possible to have a representation of the ambrosial relational thickness concept within the 8 mm horizontal corneal section, which is important for the inclusion of corneal morphology in the algorithms that I will explain ahead. The stiffness parameter at the first applanation created by the group of Cynthia Roberts was proposed as the most accurate in defining global eye rigidity. It includes both the basic air puff pressure and the Corvis-based biomechanically corrected intraocular pressure, which is itself an algorithm created by Vinci Guerra, but is out of the scope for this presentation. But, in fact, in the subset of refractive surgery ectasia screening, what is important regarding the aforementioned parameters is the idea of what is the pattern of biomechanical behavior when they are lower or higher. This can be analyzed through the Vinci-Guerra report. As you can see, a softer cornea is expected to generate higher DA ratio and integrated radius values, and lower both ambrosial relational thickness and stiffness parameter at applanation 1 time point. Moving on, the Corvis biomechanical index is a purely biomechanical algorithm based on a logistic regression analysis of 6 DCR parameters adjusted for IOP and central corneal thickness, whose purpose was to detect both clinical and subclinical corneal ectasia. It showed high sensitivity and specificity for the detection of corneal ectasia with a cutoff of 0.5. However, as it is a score from a logistic regression, as you can see with this shape of the curve, values between 0.2 and 0.8 are associated with a similar ectasia risk and are not truly informative. So, we have to keep in mind the inferior and superior limits of that moderate risk interval as the cutoffs to both normal and high-risk corneas respectively. Additionally, more recently, the group of ambrosial reported increased accuracy for subclinical ectasia detection with a cutoff value as low as 0.07. Nonetheless, the association of tomography and biomechanics is vital towards the study and comprehensive assessment of ectasia risk. Given this, an algorithm generated by the random forest method with leave-one-out cross-validation, including tomographic and biomechanical parameters, was created. It is the Tomographic and Biomechanical Index, TBI. Here you can see the Ambrosio-Roberts Vinci-Guerra display, which is a friendly-faced way of getting all together the main information needed for a proper ectasia risk screening. As you can see, it includes tomographic information from the curvature axial front map, pachymetric map and progression, and the BED that Professor Fernando Faria will talk about. The aforementioned main biomechanical second-generation parameters are included too, with a highlight for the CBI. Then, the TBI appeared as the ultimate parameter, including information from both devices. One important thing to keep in mind is that besides the green range of the 3 parameters with a superior limit from normality, those are not static values, and knowledge is evolving given evidence for new cutoffs. I already talked about the CBI value of 0.07 for subclinical ectasia detection, but with the TBI is the same story. In fact, in this important work from Professor Amblosio and colleagues, the TBI had 100% of sensitivity and specificity to detect frank ectasia cases with a value higher than 0.91. However, after optimization of the cutoff to 0.29, was even able to discriminate subclinical ectasia among eyes with normal topography in very asymmetric patients with a higher area under curve than CBI or BED-D. But in the subset of refractive surgery screening, we should not forget that even the most accurate biomechanical corneal characterization needs to be integrated with both the amount of error to correct and the procedure to choose. Thanks for the attention.
So thank you very much. I think we still have a few seconds for discussions. Dr. Baptista is still here. Dr. Fernandez, are you still here also? Yeah. And Dr. Ferreira is not here? No? Okay. So I think we have learned that we can use the Pentacam AXL Wave, the Corvis, and the keratograph more or less to solve any kind of problems or to screen any kind of patients. And if we compare that to like 20 years ago when we started with the first Pentacam, I think it's a completely different world. So Dr. Fernandez, what would you say in this aspect?
Well, from a humble point of view, I think as we show in the presentation, it's not only about the hardware. It's not only about a complete device for the surgeon of anterior segment. I think the key is the software. And we have a software evidence base with an incredible amount of evidence, high-level evidence of diagnosis. So for us, it's absolutely indispensable in our daily practice. And it's based on that, more than the hardware. In fact, all the competential industry need to develop, take the idea that it's not only the hardware. We need, for our daily practice, develop all the software based on evidence. This is the key for the success of this equipment.
Yeah, thank you very much. Dr. Baptista, I really love also the Corvis system, and we use it quite a bit in our keratoconus patient. What do you think the impact of using this? Like 10 years ago, we didn't even think about, or 20 years ago, having this type of examination. And I think it has opened so many ways now. Would you like to comment on that as a kind of final statement now?
Yes, good morning. Indeed, and that's for that reason in which today we have new clinical entities surging, and we have to go beyond a detection of keratoconus or subclinical disease to a thorough characterization of the individual biomechanical properties of the tissue, like a fingerprint. In that way, we have to go ahead of the subset of keratoconus and start to think about biomechanical behavior as an individual concept. And that way, we are more likely to improve and detect when even you don't have subclinical disease. You only have the predisposition.
So with all these tools, to summarize this symposium, we kind of get really to a point where we personalize our approach in diagnostic, in identification of the anatomy of the individual patient, even in the approach of calculating certain IOLs or using different type of IOLs. We really getting here to a personalized medicine, so to say, based on a broad application of these methodologies. And I think this is the way to go. And if we just think in future, in a couple of years, I don't really know how far that can go, but I think the future is pretty bright for us here on this topic. And I think we are more or less at the end of the symposium. So I think, oh, there's one question. Maybe we can answer that. Let me check on this. Oh, it's just a comment. Okay. Okay, thank you very much for this nice comment from Jairus Daya. So I thank you very much for your great lectures, and I hope that everybody who listened to this symposium was quite happy with it. And with all this, I thank you very much, and we conclude this symposium here. Thank you very much.